Hello and welcome to BLC Coding Prep. This is BLCPREP001, Compliance and Regulatory. My name is Regina Bassett and I will be your instructor today. Future in healthcare. Healthcare services make up one of the largest industries in the United States. There is a growing need for certified medical coders. A coder must maintain a high level of accuracy and attention to detail. You always want to code to the highest degree of specificity. We're going to talk next about our learning objectives. In this module, you're going to learn about a future in healthcare, some healthcare terminology, documentation requirements, what is medical coding, the different types of payers. We're also going to discuss CMS, medical necessity, NCDs and LCDs, which are national and local coverage determinations, RV, the NCCI edits, the global surgery package. We're going to talk about charge master, HIPAA, high-tech, fraud and abuse, and compliance. Again, I know that's a lot of bullets there that we're going to go over, but believe me, these are things that you will need in the field to have a general knowledge of. Again, just really kind of just study your handouts and your guides and do some research. Look up, go to CMS. There will be some different links to CMS in the classroom. There's access to the NCCI edits. There's going to be a link there to the NCDs for Medicare and Medicaid. So a lot of information is out there free of charge. So I always say my course is the first step to success. This is where you kind of get your break-in into healthcare administration, or health information management. It's a modern time name that they identify it as. But there's also advanced college work that you can do. Advanced health information occupations, you can be an RHIA or an RHIT through a HEMA. Both of those certifications do require at least an associate's degree and your bachelor's. And then you have your non-degree health information management occupations, which are the certified coding specialists, medical billers, patient account reps, AR specialists. So standards have been established to protect the public from potential harm caused by incompetence. When I began in the field, there was no such thing as certification. So a few years back, they said, look, we want to make sure these people are certified, they have knowledge, they're competent and, submitting correct and accurate bills. So they, kind of developed certifications throughout the industry. And I can tell you now that majority, 99% of all healthcare entities do require some type of certification. And not even a college degree, but maybe at least a certification. Some will give you 6 months to get your certification, or if you're in school, they will. It just depends on the employer. So they came up with different testing along with various approval and monitoring mechanisms that have been developed to determine the worker has met specific standards. So the test is the certification test that you guys are here for, to prepare yourself to sit for. And then you'll have to keep continuing education units, CEUs, of course, to maintain your certification. So a coder's responsibility is to ensure that there's accurate coding based upon the services provided and documented. When you're coding correctly, based on the documentation, you'll be able to obtain correct reimbursement for the services rendered. You never want to upcode or downcode. So you want to think like a healthcare worker. You want to learn for understanding, not simply to accumulate facts. Apply learned material to new situations. Have an organized approach to solve a problem. Base decisions based on facts rather than opinions. Locate reliable sources of information to which make those decisions. basing decisions on ethical principles, practice good communication skills when gathering and distributing information, understanding exactly what one is legally allowed to do in one's profession, known as their scope of practice. So let's talk a little bit, introduce you to some healthcare terminology. Health insurance. Basically, health insurance is a contract between a policyholder and an insurance carrier or government program to reimburse the policyholder for all or a portion of the cost of medically necessary treatment or preventative care rendered by a healthcare provider or professional. Facilities. So we're going to talk about a hospital, and I think everyone here knows what a hospital is. Just kind of want to go over the, the certification terms, what they want you to know a hospital should be. But basically, a hospital is a traditional facility for all the care of all the ill and injured. Various levels of care typically include the following in a hospital. You will see an ER department, an ICU, a general unit, psychiatric, cardiac care unit, or a transitional unit. Your ambulatory services, these are services that do not require hospitalization, also well known, you will hear it more called outpatient services, which they include the many of the diagnostic, treatment, and rehab facilities that account for most patient care activities. Nursing homes, a skilled nursing facility, provides nursing and rehabilitation on a 24-hour basis. An intermediate care facility, an ICF, provides personal care, social services, regular nursing care for patients who do not require 24-hour care but are still unable to care for themselves. You have home health providers. Home health providers are coming back on the market because they help patients have shorter hospital stays because they're going in the home catching some of the illness and injuries, before, it escalates to where they need hospitalization. And then also the increase in elderly population, people are living longer. And then they have advances in equipment. You have portable x-ray machines, mammogram, EKGs, and so forth. Hospice. Hospice refers to palliative care that relieves but does not cure, and is support provided to dying patients and their families. Quality of care. This is the biggest thing in healthcare now. This is a related area of concern, is that insurance companies and healthcare organizations emphasize on profits more than they ensure high quality patient care. When you get into the field, if you're not already in the field, you're going to hear a lot about quality reviews, peer reviews, star ratings. Again, it's not based, healthcare is changing. It's not based on how much time you spend with the patient, but the quality of care that you're giving to a patient. The rising cost of healthcare has prompted all levels of government as well as the providers of healthcare to imitate cost controls. To help healthcare workers are guided by principles outlined in a professional code of ethics. While they vary in detail, the codes all share the same purpose. Consent. Consent is when a procedure has been explained, including possible consequences. The patient's permission is known as informed consent. A living will. This document outlines the patient's wishes regarding the type and extent of care to be given. A durable power of attorney. This is where a patient designates specific people to act on their behalf if they become unable to make health care decisions. Let's see, anything else? I want to talk about on here. Consent forms can be legally signed by mentally competent adults who are not impaired by medication. In most states, adult is defined as someone over the 18 years of age. Emancipated minors are individuals under the age of 18 who are financially independent, married, or in the military. Medical documentation. If it's not documented, it didn't happen. Medical documentation refers to the notes and documents that the healthcare workers add to a medical record. A medical record refers to the collection of all documents that file together for a complete chronological health history of a patient. A medical record is also frequently referred to as a medical chart, patient chart, or patient's record. In your medical chart, you may see lots of different documentation. But that documentation needs to be complete and accurate. It is critical in providing consistent patient care. It is the lifeline of communication that supports the coordination of care. The medical record should be complete, properly identified, correct spelling and terminology, punctuation and grammar, should be signed and dated for all entries entered into the record. It should be concise and factual, legible, clearly and objectively expressed, and must have hospital or facility approved abbreviations and signed by the proper person. So in a medical record, you're going to see some of these documents. You may see nursing notes. You may see laboratory test results, ancillary test findings, admission records, hospital visits, or what we know, you'll hear them often called as progress notes. You may see a consult, physician's orders, admissions, surgical procedures, graphics, medication record, and again, progress notes. So when a patient is seen by a provider, there's an acronym that they call SOAP. And it's kind of like identifies what happens when a patient seeks medical care. So in the beginning of the note, it should be a subjective. And this subjective information is what is sent and reported by the patient. This is what the patient is telling the doctor what's wrong in their own words. The objective is information that includes the observation of the healthcare personnel. This is where the doctor actually examines the patient. An assessment. The assessment is the healthcare professional's impression, a professional impression of what is wrong with the patient based on their signs and symptoms. The plan, this is how they're going to treat it. Are they going to have surgery? Are they going to put them on a medication? What type of instructions are they giving them? So the next slide is I thought it was a good, simple example of a SOAP note. So this is a patient returning that had a diagnosis of shingles. The patient is there because they're having right hip pain and leg pain. So the subjective, the patient stated that the shingles are beginning to heal up more, but she still has pain that goes down into the right leg and now stays over into the right hip. The objective, this is where the doctors examined him. He's saying the patient had palpable tenderness over the right greater trochanter and up in through the gluteus medius area. So his assessment was that they have right hip and leg pain. Their plan, they're going to continue to treat the patient with their exercises and stretches as so forth documented. So you're here to become a certified coder. So these are some of the skills that you need to possess to be a certified coder. You should have at least a intermediate level of medical terminology, anatomy, and physiology. Again, coding has become more clinical, which makes medical term and A&P a must study. Okay, you guys, you have to study your A&P and your medical terminology. Again, this will help you so much. It will definitely help you. Accurate assignment of diagnosis, procedures, and physician services. A coder must have the proficiency to include E&M, which are evaluation and management, code anesthesia services, surgery, radiology, and pathology services. A coder also must know the coding rules and regulations, including compliance and reimbursement. A coder should also understand medical necessity, claims, denials, bundling, and charge capture. So what is medical coding? Coding is the process of translating written or dictated medical record information into a series of numeric and alphanumeric codes. There are 3 code sets, and these are the 3 books that you will need. You will need your CPT. This book has your medical and surgical services and procedures, your ICD-10-CM, which is a book that has all of your diagnosis codes, and then your HCPCS is kind of like where all your supplies, your prosthetic devices, and then there's other things also there in HCPCS that you would use for Medicare. So CPT and HCPCS, again, these are codes that are translated from services, procedures, supplies, and drugs supplied to a patient. The ICD-10, again, translates diagnosis into a standardized code that explains why services or procedure was performed. So what is the purpose of medical coding? Data collection, quality of care, determining cost and reimbursement. So accurate and specific code assignment is based on the documentation in the medical record and coding rules that pertain to each code set. Often rules vary based on who is responsible for costs, such as if it's a self-pay or an insurance company. If the record is inaccurate or incomplete, coding cannot be translated to the highest degree of specificity. So in this particular course, for this 10-week, we are preparing you for outpatient coding. You will hear there's inpatient coders and then there's outpatient coders. This particular course will build you for an outpatient coding services. However, you can work in an inpatient hospital with this certification. Because the outpatient services, you think about the emergency room, the physician's office, the outpatient clinics, facility outpatient clinics. You have all your little urgent care facilities out here now. So when you're doing outpatient coding, you are going to use all 3 of your coding books, your CPT, your HCPCS, and your ICD-10-CM. And then you'll also learn about ambulatory payment classifications, which are APCs. In inpatient, you're going to use the ICD-10-CM, but you're going to use another book called the ICD-10-PCS. You do not have to purchase this book. This book is the equivalent of the CPT, but these are codes assigned for procedures that are done in a hospital setting. Some employment opportunities, again, for inpatient, your hospitals, your short, long-term care facilities, and then also, again, in your facility outpatient clinics. Place of service. This is a 2-digit code that is submitted with the claim. It tells the insurance company, where did this visit take place? Was it in the home? Was it in the office? In your book, there's an appendix that has the place of service codes, or there is a graph of your place of service codes. Please tab that. I have seen on a couple certification prep exams, they are asking questions about that on the certification test. So please tab that area. I know Kenya, if she has not done the tabbing class with you yet, she will be doing it shortly, and to make sure that you guys know that you definitely want to tab that section of your CPT book. Place of service information is often needed to determine the acceptability of direct billing of Medicare, Medicaid, and private insurance services provided by a given provider. The example that they give here, the CPT code, which is a procedure 94002, which is ventilation assisted management, initiation of pressure or volume preset ventilators for assisted or controlled breathing in a hospital inpatient or observation on the first day. This code would not be appropriate for reporting it in an office or at a home place of service because the code description identifies that this is a hospital inpatient or observation. So once you get on your job, you will probably be working with 3M, Epic, EHRs, which are electronic health records. Believe it or not, we do still have providers that are still using paper, but most of them are using EHRs. So the example that I gave here is a kind of a screenshot of, I believe it's Epic, I believe where I got this from. But if you look, you can see like if they did services, they gave school physicals. When they build out that procedure, they would use 03 for the place of service code. If it's inpatient, 21. If it's in the office, it's 11. If they provided services in the home, it would be 12. Again, very easy to remember because it's right there in your book. The grid is. So hierarchy of providers. There are physician extenders out here now, which are, and I'm sure everyone's heard of, nurse practitioners, PAs, physician assistants. They are pretty much just a lower, they call them mid-level providers. Different providers have different levels of education, and each state has a scope of practice guidelines. So again, a nurse practitioner in Mississippi may not be able to have the same assignment or duties as someone that has limited nurse practitioner services in Illinois. So you have to know what their scope of practice or what part of medicine, because some can't write, most of them can't write a prescription. They can diagnose. You're not going to see any nurse practitioners really doing procedures. They're really going to see face-to-face encounters, usually in the office. You really see most of them now in an office setting or in an outpatient. You're not going to see a nurse practitioner performing any type of procedure other than a minor procedure. So we're going to jump over here and talk about payers. Well, there are two types of payers. There's commercial and government. Your commercial insurances are your Aetnas, your United Healthcare, Humanas, and then you have your government, which is Medicare and Medicaid. You do need to remember this for testing purposes. Medicare is coverage for 65 or older, blind and disabled, permanent kidney failure, or someone at the end stage renal disease. However, they can be disabled as well. I think they have to be disabled for at least 2 years, and they can sign up for Medicare. Don't quote me on that, but I think that's the going timeline. Medicaid is government insurance for low income folks, and especially women and children, and they're sponsored by the federal and state governments. CMS, or you will always hear it called, but it is the Center for Medicare and Medicaid Services. It runs the Medicare and Medicaid program. But CMS delegates daily operation to fiscal intermediaries, or FIs and Part B carriers. FIs and carriers are usually insurance companies. So what they're saying basically here is that CMS is not processing claims. They've contracted out to the insurance company to process claims and pay claims, submit medical necessity, and Medicare pretty much just pays them. Now, this is something that you do need to know: a participating provider and what a non-participating provider is. A participating provider has a signed agreement with the FI and the carrier. This provider agrees to accept what the fiscal intermediary and the carrier pays as payment in full. There you'll hear it say, or them call it, they accept assignment. For non-participating providers, they may get paid by Medicare and Medicaid, but they're going to get a significant decrease in the reimbursed amount. When billing Medicare and Medicaid for all providers, they will need to have a 10-digit number assigned to cover all healthcare providers, and you will also hear this called the provider's NPI number. So let's talk about Medicare. Medicare pays 80% of Medicare allowed amount of covered services for Part A, and then the beneficiaries pay 20%. So basically, what they're saying is that there's a deductible for a Medicare patient. Once that patient meets their deductible, they go in the hospital. Medicare will pay 80%. The patient or the beneficiary will be responsible for the remaining 20% unless they have a second insurance. And most times they do. They'll have either a Medicaid or their husband retirement or, what have you. So an overview of Medicare, and you will need to know this for testing purposes. For 4 parts, there's Part A, Part B, Part C, and Part D. Part A covers inpatient hospital care, skilled nursing, hospice, and home health. Your Part B Medicare covers physician services, outpatient care, some preventative services. It's an optional benefit, and the member does pay a premium to have the Part B, and there is a yearly deductible and also a co-insurance. Part C is called Medicare Advantage. It kind of combines Part A and Part B together. They cover the hospital and the inpatient and the outpatient, and even some costs of prescriptions, which is Part D. They may charge co-payments, co-insurance, or deductibles. Which brings us to the last one, Part D, which is a prescription drug program. And usually this program is ran by private insurance companies. Medical necessity. You will need to know this for testing purposes. A service or supply that is required to either diagnose or treat a medical issue is considered medically necessary. Additionally, the service and or supply must meet the standards of care. A physician should only bill services that meet Medicare's standard of reasonable and necessary for the diagnosis and treatment of a patient. NCDs, which are also called National Coverage Determinations, explain when Medicare will pay for items or services. Each Medicare administrative contractor, which you'll hear referred to as a MAC, is responsible for interpreting the policies into regional policies called local coverage determinations. So basically there's kind of 2 guidelines. If there's not a national guideline or a policy, you will see a local policy or a rule based on that region or that area. So your LCDs, they explain when a given service is indicated as necessary. It gives you the guidance and coverage limitations, which specific CPT codes that they will pay for, a list of ICD-10 codes that support medical necessity for that given service or procedure. It only has jurisdiction in their regional area. If there is no NCD that exists for an item, it is up to the MAC to determine. Providing a service that does not support medical necessity requirements per the LCD, the service may not be covered. So make a practice of obtaining an ABN, an advanced beneficiary notice. Again, guys, you will definitely need to know what an ABN is. And we're going to talk about that on the next slide. But if you notice also on the slide, I did give you the link to the LCDs and the NCDs. You can copy that, put it in your favorites. We won't get into it too much, but it's good to have, and we're going to talk about it a little bit because the test is not based on payer guidelines. It's based on, your knowledge of learning how to abstract a code and so forth, because they can't test you on payer guidelines because there are so many different payers and they all have different guidelines. So an ABN, this is a standardized form that explains to the patient that before a service or procedure, why Medicare may deny the service. It protects the provider's financial interest and is required before a provider can bill the patient. So kind of sum this up. Basically, if there's a procedure that needs to be done, but it's not covered by Medicare, the provider would need the patient, if they wanted to continue with that surgery, to sign an ABN stating that this is not covered by Medicare. We're going to bill it. However, once Medicare denied, you are going to be responsible for this bill. They cannot perform any procedure that is not covered by Medicare and bill the patient if they did not get an ABN before that procedure. The provider should provide a good faith effort of reasonable and estimated within $100 or 25% of the total cost, whichever is greater. They will test you on this, guys, so study that part. Non-Medicare payers may not recognize an ABN. So if they're not, Medicare and Medicaid, they could be Blue Cross or Blue Shield. The contract may have a hold harmless clause found within the language that prohibits the billing of the patient for anything other than copays or deductibles. RBRVs. Physician services are standardized using RBRVs. Basically what this is, they have broken down the payment that they assign a dollar amount basically to each code. And how they come up with that dollar amount is based on these three principles, or these three key components. 52% of the payment is based on the physician's work. How long did it take him to perform it? What was the technical skill? His mental and physical efforts. Was there stress due to risk to the patient? 44% is practice, the site of service, whether it's the office or the hospital. And then 4% of that reimbursement is going to be for their liability insurance. RVUs are a national standard used for measuring productivity, budgeting, allocating expenses, and cost benchmarking. They represent a relative amount of physician work, resources, and expertise needed to provide services to the patient. The actual dollar amount of a payment for the physician services results only when a conversion factor, $1 per RVU, is applied to the total RVU. So the total RVU consists of three key components. The work RVU is related to the direct expenses associated with what the physician receives for payment and salary and direct benefits. The practice expense RVU, which represents the cost to operate the medical practice and is related to the general overhead expenses of the practice. There are two types of practice expense, facility and non-facility, either the hospital or the office. Your malpractice RVU, this estimates the relative risk of each CPT code. This is related to the cost of the malpractice insurance for the physician and the practice. So again, they are not going to test you on this. They will, but they're not going to have you calculate it, put it that way. They shouldn't. I haven't seen that yet. But basically, they're taking that work RVU times the GPCI plus the practice expense RVU times the GPCI, and then the malpractice RVU, while the payment formula is the total RVU times that conversion factor for the year in question. Your NCCI edits. There is a link at the top of the course. You will see certain things being put up there. We may find an article, we may find a website, or just something extra. Again, it's not required. Usually you will find it at the top of your course when you log in, and it's just extra, data or information that you can go out and look at. But I did give you this link because once you get in the field, and if you're doing procedure coding, this is a very valuable tool. Again, this is a free download. I don't know, a lot of people don't know about it. They don't use it because some of the encoders it has it already built in. But you have to remember, if you're in the provider's office, their office EHR is probably going to really pertain to them. They're not going to have a lot of procedures done in the office, so you're not going to really see this in a office setting because they're not performing any surgeries in the office. So basically, CMS developed this, and it's called the NCCI, which is the National Correct Coding Initiative, to promote national correct coding methodologies and to control improper coding leading to an inappropriate payment in Part B claims. CMS developed its coding policies based on coding conventions defined in the AMA CPT manual, national and local policies and edits, coding guidelines developed by national societies, analysis of standard medical and surgical practices, and a review of current coding practices. The NCCI edits are updated annually. And again, if you see, the link is there, but it has also been posted into the course classroom. Healthcare providers use both HCPCS and CPT codes to report medical services performed on a patient to Medicare and fiscal intermediaries. You have your CPT HCPCS Level 2 codes, which define medical and surgical procedures performed on patients, but the Level 2 code descriptors usually did not define all services included in a procedure. So the CMS developed the NCCI to prevent inappropriate payment of services that should not be reported together. The way that you will use this tool, and we're going to do this probably when we get in coding surgery, we'll look at some of the NCCI edits. But what they call is MUEs, these are medically unlikely edits. These will prevent payment for an inappropriate number or quantity of the same service on a single day. An MUE for a HCPCS or CPT code is the maximum number of units of service under most circumstances reportedly by the same provider for the same beneficiary on that same date of service. So I kind of gave you a little snippet of what this is. Prior to April 1st, 2012, edits were placed into either a column 1 or column 2 correct coding edit table or the mutually exclusive edit table. However, in 2012 of April, the mutually exclusive edit table were moved to the column 1, column 2 correct coding edit table so that all NCCI PTP edits are currently contained in this single table. Combining the two tables simplified researching the NCCI PTP edits. So basically what I can, just to sum it up, that's a lot of verbiage for something that's pretty kind of easy. But if you will look at, and I know it doesn't give you the columns, where you see the 81211, that is a lab procedure. I'm not sure which one it is. And then you have 81213. What they're saying is that 81213 cannot be billed, should not be billed with 81211. This policy came in effect April 1st, 2013. However, it does have a 1. So what that 1 means is saying, yeah, we can bill it, but it needs a modifier. But if you see 0, that's telling you those two codes on that line. If you look under the line 81211 and 81214, again, you will see a 0. It's a more extensive procedure. They're saying that these two cannot be billed together. So that kind of gives you what your NCCI edits does. Again, a lot of the EHRs right now have it built in because you're in a facility. But if you have a provider, if you're working for a surgeon and you're billing out, you should have access to the NCCI edits, and you should be using those rules as well. Procedures shall be reported with the most comprehensive CPT code that describes the services performed. Physicians must not unbundle the service described by a HCPCS or CPT code. The example here, they said that a physician shouldn't unbundle a bilateral procedure code into a unilateral code. So just to give you an example or explain the example that they have. So the physician performed a bilateral mammogram. The code for that would be 77066, which is a diagnostic mammogram bilateral. Bilateral is in the code description. However, there is another code, 77065, that says diagnostic mammogram unilateral. That means they're only going to do a mammogram on one breast. Don't bill that times 2 because you have a code. If they did the left and the right, you don't want to bill that 77065 for the left side, then bill it again for the right side when you have a code that clearly identifies that both breasts had the mammogram done. A physician must avoid down coding. Just to kind of explain that, a lot of providers, when we get into E&M, there's like levels of service, like level 5 is the highest and level 1 is the lowest. And a lot of providers don't like billing level 4s or level 5s because they're in fear that they might get audited if they're doing too many high codes or high level codes. But you don't want to downplay your work. Some of them, do deserve a level 4 or level 5. But we have some providers that say, oh, just bill it a level 3. I don't want Medicare on my back saying I'm overbilling or anything like that. But you don't want them to lose money. So that's our job as coders, to, help the provider, get as much money as he possibly can and not throw money away. Let's see here. Physicians, again, must avoid upcoding. Again, that's charging more from what they've done. Physician must report the units of service. What did they do? If they did 2 x-rays, they should bill for 2, not 1. Each CPT code or HCPCS code has a defined unit of service for reporting purposes. And basically what that's saying, in your descriptions, when you start going through your CPT book, you may see unilateral, like we just talked about, or each, or per, up to. So if that particular code has a quantity type description, that's saying how many times that service can be performed, or how many sites can be performed for you to assign this code. So from coding to payment, billing and coding are separate processes, but both are crucial to receiving payment for healthcare services. Medical coding involves extracting the billable information from the record and clinical documentation, while medical billing uses those codes to create insurance claims and bills for the patient. Creating claims is where the medical billing and coding intersect to form the backbone of the healthcare revenue cycle. The process starts with the patient registration and ends when the provider receives full payment for all services delivered to the patient. The medical billing and coding cycle can take anywhere from a few days to several months, again, depending on the complexity of the services rendered, management of any claim denials, and how organizations collect the patient's financial responsibility. When submitting medical claims, not only do you need to get their code to right, but you also have to apply the right rules. HIPAA mandates that providers and payers use the same codes, but some payers can vary the payment policies and coding requirements. So every payer is going to have or accept a CPT, ICD-10, or HCPCS code. Now, they may pay it differently, but they all will use the same codes. The information for private payers can be found in the provider-payer contract, payment policies, and provider manuals. One of the biggest mistakes a practice can make is applying Medicare rules to all payers. Medicare rules are totally different. So when we start getting into the coding, which is going to be a couple of weeks, we'll do ICD-10 next week, and then we'll do intro to CPT and I believe the anesthesia. But anesthesia is not really a surgery, so you have about 2 weeks before you start on surgery coding. But a global period. All procedures on the Medicare physician fee schedule are assigned a global period of 0, 10 days, or 90 days. If a procedure has a global period of 90 days, it is defined as a major surgical procedure. If it has 0 days or 10 days, it's a minor surgical procedure. The graph here kind of gives you some example. So if a patient had an epidural or a nerve block done, there's no post-op time. There's no, they got to come back and follow up. So there's no global period. For a 10-day, which is a minor procedure, it may be an epidurolysis, a neurostimulator, or implantation. So pre-op days, there's usually none, but they can follow up 10 days from that surgery. So what they're saying is that basically if that patient, say on day 1, they had, I don't know, we'll say they had an implant, and say a couple days later, they go back to the doctor because it doesn't feel right, to ask questions. But because it's within that 10 days, that provider cannot bill for it because it's still within the global period. And then the last one, 90 days, makes sense because that's telling you that this patient or this procedure usually needs 90 days to heal or get back, or recover. So if someone's having a hysterectomy, they're not going to be able to be perfectly fine in 10 days. They're probably going to need 90 days where they feel that, they can get back to where they were prior to the hysterectomy. Charge capture. Again, this is a hospital type of lesson. However, because coders, again, are us outpatient coders are working in hospitals. And I think I told you earlier about APCs, ambulatory payment classifications, and charge capture. So basically, let me just kind of go over the slide. Maybe this might be a little bit better than me explaining. Let's see how this works out. And if it doesn't explain it the way I want, I'll come back and kind of give you my version of it. Again, you're only going to see this in a hospital setting. But it states that coders also connect physician order entries, patient care services, and other clinical items with a charge master code. Well, a charge master is a list of the organization's prices for each service offered at that provider organization. The hospital charge master is how providers communicate medical bills to payers and patients. Comprehensive maintenance is key to prevent revenue leakage. The charge master captures the cost of each procedure, service, supply, prescription drug, and diagnostic test provided at the hospital, as well as any fees associated with those services, such as for the equipment or room charges. Charge capture through the charge master is an integral component of a hospital billing process. So they kind of explained it. Basically, it's a big price sheet. So you always hear people, they bill you for the aspirin, they bill you for that bedside commode, they bill you for, all those little things. All those fees are listed in the charge master. So when they're in there entering them, they'll bring all those fees together. When a patient receives services from a hospital, providers document the encounter in the medical record, and health information staff or professional coders assign codes for reporting and claim submission. Those codes and documentations are translated via charge capture to the charge master rates. The charges are then used to bill the patient and create claims for the payers. Maintaining an accurate hospital charge master is key to revenue integrity. An inadequate charge master can result in overpayment or underpayment, as well as claim rejections, undercharging for services, and compliance violations. So the charge master includes the following. It'll include an item number that is assigned by the facility and unique to one service line item, it should have a CPT or HCPCS code, an item description that translates the CPT or HCPCS code into a short text description. A revenue code is assigned. The charge amount or fee assigned to the service line item. Alternative CPT or HCPCS codes if it overlaps or additional codes are needed for a specific payer. Numeric designation for that department or from what department that came from, and a general ledger number for accounting purposes. Most hospitals have charge master teams or coordinators who own the process. The team typically includes a director of finance, controller or charge master director, support staff, including a charge master analyst, nurse auditors, and other financial staff. The charge master team or coordinator responsibilities should include: they should gather departmental reviews, delete or replace codes, assign revenue codes, reviewing code changes and rates, identify rates below the Medicare rate, educating other staff on pricing and billing processes. Charge master teams should also partner with the coders and billers to make sure clinical documentation and coding practices align with the charge master. Privacy and security, HIPAA. The Health Insurance Portability and Accountability Act of 1996 was enacted by the 104th U.S. Congress and signed by President Clinton in 1996. It was created primarily to modernize the flow of healthcare information, stipulate how personally identifiable information is to be maintained by the healthcare and the healthcare insurance industries and should be protected from fraud and theft. And it also addresses limitations on healthcare insurance coverage. HIPAA provides federal protections for protected health information. You will hear this a lot, PHI. Protected health information when held by covered entity. You will need to know these few slides that I'm talking about. I know Kenya will probably, me and Kenya both are a big believer of practice makes perfect. So even with the information that you're getting here, again, we will be creating Practice Makes Perfect. So you can go in there and just keep practicing because you are going to need to remember this for testing purposes. And the reason why I do stress this and I do tell you guys to go in and do your PMP, because once you start coding, it's so intense, and we won't go back to compliance and regulatory for the rest of the course. So you may forget some things. So we have some PMP practicals out there that you can take. They don't go against your grade, just extra practice, and those will also be placed in your classroom, a link in the classroom. 9 times out of 10, it'll be linked. The practice will be linked to whatever section we're going over. But if not, it'll be at the top with the other resources, and it will be a link to class marker. We are no longer using electrolyzed quizzes. It's just had too many glitches. So you should have received a login to class marker. Log in. You should have some things there now that you have access to, like medical terminology practice and A&P practice. So, didn't want to kind of go off the rails there, but I did. Let's talk about privacy and security. HIPAA provides federal protections for PHI when held by covered entity. A covered entity may be, you will need to remember these, a healthcare provider, doctor, clinic, psychologist, nursing homes, pharmacy, health plans, your health insurance company, your HMOs, company health programs, even government programs, and the clearinghouse. Patient confidentiality. Privacy is the right of individuals to keep their information from being disclosed to others. It is essential that confidentiality of a patient's information is maintained. Confidentiality involves restricting patient information access to those with proper authorization and maintaining the security of that information. So you'll hear the it word of minimum necessary. Only the minimum necessary PHI should be shared to satisfy a particular purpose. Under the privacy rule, the minimum necessary standard does not apply to disclosure or requests by healthcare providers for treatment, disclosures to the individual who is the subject of the information, uses or disclosures made pursuant to an individual's authorization, uses or disclosures required for compliance with the HIPAA Administrative Simplification Rules, the disclosures to HHS, which is the Health and Human Services, when information is required under the privacy rule for enforcement purposes, or uses or disclosures that are required by other law. High tech. This is the health information technology of economic and clinical health. High tech was enacted as a part of the American Recovery and Reinvestment Act of 2009, which was signed into law February 17th by President Obama to promote the adoption and meaningful use of health information technology. High tech strengthened HIPAA rules by addressing privacy and security concerns associated with electronic transmission of health information. It also allows patients to request an audit trail showing all disclosures of their health information, and it also requires that the patient must be notified if there is an unauthorized disclosure. Fraud and abuse. CMS, and I'm going to put that link in there as well. I need to update you guys' link. But CMS has a, oh gosh, MedLearn, where you can go in and they actually have an online course. You can get a certificate for fraud and abuse. I will put that link in there. Again, it is not required. I mean, I would go look at it just for extra studying purposes. I will give you the access to it. They will be asking you about fraud and abuse on your certification exam. So again, this is another very important topic that you need to familiarize yourself with. The Office of the Inspector General, which is the OIG, is mandated by law to test the efficiency and economy of government programs to include investigation of suspected healthcare fraud or abuse. Fraud. This is to purposely bill for services that were never given or to bill for a service that has a higher reimbursement than the service provided. Blah. The ACA, which is the Affordable Care Act, amended the definition of fraud to remove the intent requirement. A person does not have to possess knowledge of the violation for it to be still considered an offense. Abuse, this is for payment for items or services that are billed by the provider in error. Compliance. All healthcare facilities and physicians should actively use a compliance program. A compliance plan is a written set of instructions outlining coding and billing accurate claims. A compliance plan offers internal controls in reimbursement, coding, and payment areas where coding and billing are often resources of fraud and abuse. The benefit of having a compliance plan, you're going to have more accurate payment of your claims. There are going to be fewer billing mistakes, improved documentation and accurate coding, and then there's a less chance of violating the self-referral and anti-kickback statutes. Determining the need for a compliance plan. Again, it depends on the size of the practice, their specialty, and their coding practices. So what are some things that can trigger an audit? A patient complaint, an employee complaint, level of service distribution inconsistencies, information from other investigations, and then looking at the data from claims that have already been submitted. So there's a lot more to fraud and abuse and compliance. Again, just kind of study up. I will be giving you more and more practice. Again, we encourage you guys to Google however you want to do it. To study, but again, the information or the practice questions that we give you will pertain to the healthcare compliance field. So you may have to do a little research on your own to kind of pull that information. And then also in class marker, you will get the rationale of where that information came from, where it's cited from. So it will also give you another study tool. Well, that completes BLC Prep 001, Compliance and Regulatory. Please take notes, go back, kind of re-listen to the recording. There will be a practice, PMP practice for compliance and regulatory, and then you will also have a quiz once you have your live review with myself or either Kenya. Have a great day and happy coding.